Hello, this is Gresham Markwell. I'm a DNP student at Eastern Kentucky University. I'm going to be going over my nurse's knowledge of diabetes management project with you. The purpose of this integrative review is to present evidence showing that nurses are not confident and don't feel comfortable giving information and diabetic teaching to their patients. The facility that I will be using to implement this project is a 410-bed hospital in Western Kentucky. Most hospitals use a diabetic educator to complete patient education. This facility recently lost their diabetic educator, so right now they are just using their staff nurses to complete the diabetic education. I would like to implement a diabetes education scenario using simulation to keep nurses up to date with the standards of the care and give the nurses the confidence to complete diabetes education to their patients. The healthcare problem in target population. Diabetes remains the 7th leading cause of death in the United States. 1.5 Americans are diagnosed with diabetes every year. As with all of healthcare, the field of diabetes education is constantly evolving and changing. As with all of healthcare, national standards are updated, new medications and devices are released, and best practices are evolved. Standards of care in diabetes provide clinicians with guidance to prevent and treat diabetes and its complications. The American Diabetes Association publishes the standards of medical care in diabetes annually. These rigorously reviewed recommendations provide clinicians with guidance to prevent and treat diabetes and its complications. The prevalence of diabetes continues to increase in the United States, and it presents a growing problem for healthcare. It is also a significant burden for patients, healthcare providers, and the society. Nearly a quarter of hospitalized patients have diabetes mellitus, leading to increased mortality, morbidity, and hospital complications. Patients with diabetes have higher early readmission rates compared to the general population. My selected intervention was simulation-based diabetes management and competency assessment for medical surgical nurses. To improve patient outcomes by developing a diabetes management education program based on ADA evidence-based guidelines. To enhance critical thinking with a 60-minute didactic instructor-led classroom educational session, and then increase confidence and knowledge in diabetes education by completing a competency assessment using high-fidelity simulation. I will evaluate for a change in the nurse's knowledge and understanding of diabetes management using a pre- and post-diabetic knowledge test. I had 2 PICO questions that helped me do my research. My first PICO question was, does diabetic education simulation compared to prior diabetic knowledge improve nurses' competency of diabetic knowledge and improve application of knowledge through patient teaching? Research has shown that adults have a greater need for the learning experience to be relevant to their job situation. They prefer to learn through a task or problem-centered orientation. My second PICO statement guided my search on different ways to approach patient education using a multidisciplinary approach. Studies have shown using a team approach to diabetes care can effectively help patients cope with lifestyle changes and educate about complications. This is a table of my level of evidence. I had 5 articles that I appraised and synthesized to obtain research that supports the need for more education on diabetes to assist patients with increased knowledge and understanding. These articles were randomized control trials, which are a level 2 article based on Melnick's evidence hierarchy, and one of the articles was a level 4 cohort study, and the other was a level 6 descriptive study. The strengths and weaknesses of my research. The 3 studies were similar in that they all used patients with diabetes mellitus and randomly placed them into 2 groups, providing education to each group. The differences was how the classes were structured and the length of the classes. The outcome for all three studies showed that a shorter, more structured educational program improved patients' knowledge of their disease and improved self-management skills. With MODIC 2014, the results showed the overall length of knowledge of diabetes management by nurses was lower than expected at baseline. The study also gave evidence that not only novice nurses, but also experienced nurses are not current with inpatient diabetes management. Because of the knowledge gaps, presented a need for additional resources and education to help nurses manage the day-to-day clinical questions and management of patients with diabetes. And my last study, the cohort study by Dorland and Liddy. This result showed a study comparing the outcomes of two diabetic education programs, and it demonstrated that shorter sessions using didactic teaching methods may be equally effective in producing improvements as more intensive course formats. My intervention and outcome synthesis table. You will see here that with Modic et al., the descriptive study was used to examine nurses' comfort, familiarity, and knowledge of diabetes management to explore areas where knowledge problems persisted after completing a 4-hour educational program. The results showed that the overall knowledge of diabetes management by nurses was lower than expected. With Grillo et al., this study was a structured educational course, and it was delivered in a group format. It was a useful tool to improve knowledge of diabetes and prevent progressive increase in A1C in type 2 diabetes patients. Dorland and Liddy was a retrospective observational study, and it demonstrated a trend towards improved glycemic control for participants in both programs, despite differences in class formation and format. The results of this study demonstrated that shorter sessions using didactic teaching methods were equally effective in producing improvements in diabetes. Anzaldo Campos was randomly assigned patients, and this one was 3 groups, with and without wireless technology. This study improved glycemic control and diabetes knowledge in high-risk patients by using peer-led education along with wireless technology. Zhang 2019 completed a randomized control trial on patients placed in 2 groups to assess outpatient diabetes self-management education program. The evidence supported the effectiveness of short-term diabetes self-management. Education for outpatients can effectively improve the level of self-management, psychological condition, and glycemic control in type 2 diabetes. In summary, improving diabetes care in the United States is critical because diabetes rates are increasing dramatically, particularly among minority and low-income populations. Because the number of hospital admissions for individuals with diabetes is expected to grow, it will be imperative for nurses to have knowledge and expertise to act on the recommended standards of care. By implementing evidence-based simulation education, staff nurses can improve their nursing knowledge, confidence, and provide better patient outcomes. The review of literature supports an educational intervention on diabetes management and education for nurses. Collectively, these results indicate a need for a change in the current provision of diabetes education. Healthcare professionals, particularly nurses, need to be provided with appropriate training opportunities to enable them to fulfill the requirements of their position as an influence on both knowledge and practice. Evidence exists to show that nurses working in hospitals have deficits in knowledge of diabetes and its care. This concludes my integrative review. Thank you for listening.